3, 2, 1.
Good evening, our dear friends, professors, colleagues, and fellows all over the world. Welcome everyone to the Bifurcation campus. Bifurcation campus is a dedicated module for bifurcation techniques. All you want to know about the bifurcation world will be delivered through this module. This module come, comes through Tuesdays, or what we call Tuesday intervention nights. This module will cover all the aspects of bifurcation techniques and will be of 9 case-based webinars every Tuesday. So, my friends, more details you can find on CEC Facebook page. And please let me now introduce our great speakers and moderators for today. First presentation, our speaker will be Professor Muhammad Zahran, our dear friend. Muhammad is associate professor from Ain Shams University from Egypt, and he will present to us the intro for bifurcation world. His presentation, which will be moderated by my dear friend Karim Mahmoud. Karim is a lecturer of cardiology from Cairo University. He is also our dear friends. Both Zahran and Karim used to be a great duetto everywhere. They will tell us about their presentation now about coronary bifurcations, what, when, and how to manage, and decision-making and management strategies for coronary bifurcation. The second presentation is will be delivered from our friend Dr. Ahmed Kamel. Ahmed is my friend from National Heart Institute. He is a consultant interventionist for me and for all our friends at National Heart Institute. Ahmed used to be one of the best intervention consultants at our institute. And I will moderate this session. So now I will pass the mic for my friend Muhammad Zahran. Muhammad, you are on board now. Please rock but gently, please.
Thank you so much, dear Abdurrahman, for this kind introduction. And I would like to welcome all the audience on the YouTube from all over the world, watching and sharing in this bifurcation campus, which is moderated by my dear friend Abdurrahman Gamal, and actually planned and broadcasted and shared by all the CEC board with our collaborators from all over Egypt and outside Egypt as well. So I will jump to the topic. Today's lecture is the introductory lecture to the webinar course. It includes the decision-making and the management strategies for coronary bifurcations. What is a coronary bifurcation and what is the significance of this bifurcation? When do we need to intervene and how should we manage this situation? So coronary bifurcation, what is it? As we all know, significant coronary bifurcation stenosis is the narrowing that occurs adjacent to and or involving the origin of a significant side branch. It accounts for 16% of the cases for PCI all over the practice. It actually has a higher rate of procedural complications, up to 9%, which is a high rate of complications in interventional cardiology. It has a lower rate of initial success, especially if two stent strategies are involved. And of course, the more complex the procedure, the more is the rate of the initial success. And we mean by success, it's the ability to perform the final kissing inflation after recrossing of the wires properly. And finally, although you do everything the right way, and as all the interventional cardiologists do recommend, you still have a higher rate of restenosis, up to beyond 1/3 of our coronary bifurcation cases have restenosis. So this is the classifications of coronary bifurcation. We have a lot of classification, of which the most famous is the Medina classification. The Medina classification involves using 3 digits. The first digit represents the main or the mother vessel. The second digit is the main branch, and the third digit is the side branch. You will use the digit 1 if the atheroma is involving the affected region, and you will use the digit 0 if the atheroma is not involving the affected region. So you end up with 7 options. The true bifurcations is only 3 of those 7. The 111, the 101, and the 011. And of the 16% of the bifurcations representing the cases in true intervention, 50 to 70% are one of those 3 subtypes, by which I mean it's a true bifurcation lesion. So long as the digit number 3 is involved by a 1, which is the side branch, and any other digit is involved by a 1, whether the mother vessel or the extent of the mother vessel, which is the main branch, you will get a true bifurcation. But a 110 and the 100 and the 010 and a 001 are not considered as true bifurcations. After that, we move to the definition of a complex bifurcation. What's a complex bifurcation lesion? Usually, the complex bifurcation lesion is the bifurcation lesion for which you will consider using a 2-stent strategy, or you will consider revascularizing the side branch, or you will consider that this side branch is something valuable to lose. So the true bifurcation means you have more than a 50% stenosis in both of the main vessel and the side branch, plus the burden of the atheroma extending to or beyond 5 millimeters from the side branch ostium in a sizable side branch which is more than 2 millimeters of diameter, and of course this is supplying a significant volume of a viable myocardium.
So, Muhammad,
Technically, to tackle this bifurcation, you need to assess.
so
Yes,
Muhammad, we have 3 types of bifurcation. That's what I understand. You have the bifurcation in general, which involve any of the main branch and side branch. However, we have the true bifurcation. The true bifurcation, you must have an involvement of the main branch and the side branch. And this is the 3 types you mentioned. And to upgrade into the complex bifurcation, you must have, in addition to this true bifurcation, a severe involvement of the side branch, defined as a lengthy atheroma in the side branch, large side branch, or that the side branch supplying a large territory of myocardium. I'm right?
yes.
Is it
I
all?
totally agree with you, Karim. I totally agree.
Is it all, or we need more assessment of the main and side branch for successful bifurcation intervention?
Technically, what you are speaking is exactly right. You need to assess additional features which will help you technically whether to choose a single stent strategy or a 2-stent strategy. This depends upon the main branch features, the atheroma burden, how much is it located, is it locally or is it extended, the proximal vessel diameter and the distal vessel diameter, whether you do have calcification or not, and whether the distal vessel is affected or not. According to the side branch, you will assess the atheroma burden, whether or not it is extending beyond the ostium for 5 or less millimeters, proximal diameter of this side branch, whether it's a small vessel less than 2 millimeters, or whether it is a sizable vessel. The myocardium at risk, is it a moderate or extended area or volume of viable myocardium? Presence of calcification, and the distality of the vessel beyond the lesion, is it involved or not? Because this will affect you choosing in the two-stent strategy the length of the stent that will pass to the side branch, because as the length of the stent is more extended, the passage and the technicality will be a little bit more challenging. And finally, one of the most important features that you need to assess is the angle between the bifurcation, at the bifurcation between the extension of the mother branch and the side branch. If this angle is more than 70 degrees or it is less than 70 degrees, and we will tell you later on why. So according to the Medina classification, we have the 7 subtypes, of which we chose only 3 to be considered as true bifurcations. The next question will be, how would I size the mother vessel before the bifurcation? Because, as you know, whether you choose a provisional stenting technique or whether you choose a two-stent technique, usually you choose the stent according to the size of the distal segment of the stented artery, which is represented here as D2, for instance. So if you're going to choose the stent according to the size of D2, it's going to be much smaller than the size of D1. And here you need to adequately identify the size of D1 for the proper post dilatation. And in this case, you have 2 options. The first, which is the better option, is to get an accurate measurement using an intravascular imaging technique, for example, IVUS. Or the second option is to calculate it mathematically, where you get that the diameter of the main vessel, D1, equals 2/3 the additive value of D2 plus D3. So D1 equals D2 plus D3 in total multiplied by 2/3. So if you have, for example, D2 is 3 millimeters.
Let me ask you, Muhammad, if we had a left main that shows no apparent disease, however, its size is less than the proximal LAD. How would you assess this left main bifurcation disease? The slide stopped the sharing, Muhammad.
Yes, you can see them now.
Yes.
Okay. So I didn't hear your question. May you repeat it, please?
So we have left main. Its size is about 3.5, and there is no apparent disease. And your LAD is also 3.5. Would you consider this left main as a healthy vessel, or you would consider anything else regarding this left main?
So, as I understood, you have an ostial affection of the LAD, and you have an ostial affection of the circumflex, and both of them are 3.5 millimeters in diameter. And we are asking about the left main. Usually the IVA studies, what we learned from several years from those who did IVA studies and published several papers, that what you see by your own eye to be confined as an ostial lesion is not a true ostial lesion. The atheroma is more than 90% of the cases is an extension of the distal left main. So usually in this case, your stent will have to move a little bit proximally into the left main, and you will involve a left main stenting procedure in this case. To calculate the size of the left main, you can apply this Finitz formula.
Very nice point. Yeah, you mentioned that the disease of the ostium of the LAD and circumflex usually extend to the left main. I'd also like to add, if you have a left main that its size is equals to the proximal LAD or less than the LAD, you should suspect disease in the left main, even you don't see apparent aspiroma in the left main. Based on your formula, on the
Yes.
finite formula, you always should always calculate the left main as the two-thirds of the sum of the proximal LAD and the proximal LCX, and this will help you in the proper assessment of the size of the left main.
Zahran, are you with us or there is?
Yes.
Okay,
No,
please.
no, I'm there. I'm there. I'm hearing Karim's comment.
Okay.
So the second point that we said, which is very important after assessing the main vessel and the side branch, is the angle of the bifurcation. And this is a simple geometrical explanation of what we mean. As you recognize, angle is more than 70 and more towards the 90 degrees angle, and the distal lips of the side branch, both of them are nearly aligned on the same line. So if you put a stent, and the stent, of course, after inflated, looks like a rectangle. So if you put this stent like this straight line will actually align the lips together. But if the angle of the bifurcation is a more acute, less than 70 degrees, as in figure B, and you align your stent, you have two options. You will align the stent struts having several struts protruding here. So this is the importance.
Ahmad, could you repeat again? Your connection is not working well. So, Muhammad, share your slide again.
Yes. Did you hear the part explaining the geometrical angle of bifurcation?
No, please repeat it again, Muhammad.
Okay,
So
I
repeat
will repeat it again.
the last slide, yes.
So why is the angle of bifurcation? It's important because when you see the side branch, as you know that the stent is rectangular in shape, and this line of the side branch ostium. So if this angle is more or less towards the 90 degrees, both of those lips are aligned.
Abdurrahman?
I'm sorry, I don't know what's wrong. So
There is a problem with
can
your
you hear
connection.
me, guys?
Yes, now we can hear you. So, Muhammad, can you start with this slide again? I think we lost you last time with this slide.
Yes, okay. Then, okay, so currently you cannot hear me?
Yes.
Okay. So if this angle is more or less a right angle, like a 90 degrees angle, you can align the stent at the proximal lip and at the distal lip to be covered together from the side branch. But if this angle is acute, less than 70%, and you adjust your stent at the distal lip of the ostium of the side branch, you will lose covering a part of the proximal side branch at the proximal lip. And if you pull this stent here at the distal lip of the ostium of the side branch. So this is very important because it will help you decide if you have this kind of bifurcation and you want to cover this area properly, then the two stent technique will be a little bit more towards using a crush technique rather than using a with minimal protrusion, because you cannot do a minimal protrusion in this situation. Is this clear, Karim, or do you want to have a question here?
Yes, Mohammed, I think we need to know the impact of the angle of the wire crossing and the carina shift. Can you illustrate that, please?
Yes. This is very. Why is the angle of bifurcation important? It's important for helping you wiring the side branch and the effect of the carina shift when you stent the mother vessel towards the main branch, and it will help you to choose the two stent technique for this particular side branch. And here, let me explain what is the difference between the carina and what's the difference between everywhere else in the coronary. If you are and this riveting to a right side branch and a left side branch, the stream of the water is usually faster, and which usually we call the river banks. The water is a little bit slow. The effect of the water being a little is already pulsatile by systole and diastole. It means that you have a shear stress force. A shear stress force means a force that goes to and fro, in front and behind. This shear stress force will initiate endothelial injury. And this endothelial injury will promote atherosclerosis. And this will cause more macrophages to attack those areas. So usually, the atheromas are located more at the river banks. It's located more at the side of the side branch and the extension of the mother vessel, which we call the main branch. And usually, the carina, which is the middle region, is usually free from atheroma. So this is very important. And let me imagine with you that here, if we put a stent extending from the mother branch, mother vessel, towards the mother branch, we will heal or we will treat the atheroma here, but we will cause this carina to move towards the side branch. This carina is actually healthy, but when it moves towards the side branch, it causes the ostium of the side branch to be pinched. And this pinching of the ostium of the side branch can make it visually apparent for me that it is stenotic. This is not plaque shift. This is simply a carina shift. It's more or less like the idea that you have a door between two rooms. If you want to enter to the room on the right side, you have to move the door towards the left side. So the entrance to the room on the left side is narrowed. If you want to move from the room to the left side, I mean you stent it, so the door will move towards the right side. So the ostium or the entrance to the room on the right side will be narrow. This is carina shift, and usually the carina is free from atherosclerotic lesion. And very much when we go towards provisional stenting in cases, we find the ostium of the side branch is narrowed. And then we start asking ourselves, does it need a stent or not? And then the assistant or whoever is helping you said, no, it doesn't need a stent. We did an IVA study and we have seen that this ostium is clear. This ostium is clear, it's healthy. There is no atheroma here. It's only pinched because we shifted the carina towards the ostium, which is actually healthy. And then the second question here jumps to our mind, which is usually always asked by operators. Do I need to wire the second branch? You are smart enough and you are lucky enough that the door that you move towards the other side did not occlude the entrance completely, then you are lucky enough to pass a wire and you can give a kissing balloon inflation. But what if you are not lucky enough and this carina, which is a piece of flesh or a piece of vessel, totally occludes the ostium of the side branch, and then you wanted to rewire this side branch? You were unlucky enough because your wire is not going to penetrate the flesh and pass to the side branch. And if it penetrated through the flesh, you will get a dissection and an intramural hematoma, and your night started to become an ugly night. So we will speak about wiring the side branch later on, but let me stop here for half a minute to give Karim an option to ask and moderate.
Excellent, Mohammed. I enjoyed your illustration of the carina. I confirm your points that we are dealing, that this carina, we are dealing with non-atherosclerotic segments, and the carina shift, it's the term that we should use, not the plaque shift. Let me, because we have some inputs from the YouTube regarding, again, the angle of bifurcation. And let me ask you, if we have a narrow angle and a wide angle of bifurcation, which of them we would expect a carina shift in them, the narrow angle of bifurcation or the wide angle of bifurcation? Muhammad? Muhammad, did you hear my question?
Sorry, Karim, I didn't hear it. Could you please repeat it?
Okay. So, Mohammed, regarding the angle of bifurcation, as we have some questions regarding the angle of bifurcation on YouTube, which angle of bifurcation you would worry about the carina shift, the narrow angle of bifurcation or the wide angle of bifurcation?
Of course, I would worry more acute angle. The more the angle is acute, the more the carina would be shifted towards the other side, which is usually the side branch. Because in this case, if I go with provisional stenting from the mother vessel to the main branch, the carina shift will move towards the side branch and occlude this ostium. But if it is 90 degrees, I'm very safe. If it is obtuse angle, I'm extra safe.
On the other hand, what about the ease of access to the side branch? Is it more with the acute angle or with the wide angle?
Yes, if you want to access the side branch from the start and behave like a safe operator that would not take the risk, and you want to wire both branches before bifurcation, it's very easy to wire a side branch coming out with an acute angle because it goes with the stream of the main vessel. But if it is 90 degrees, it's a little bit difficult. If it is an obtuse angle, it will be a little bit extremely difficult.
So we here, thank you, Mohammed. Narrow angle equals an easy access to the side branch in most of cases with increased incidence of carina shift. On the other hand, if we have a wide angle, this means a more difficult access to the side branch, however, with a less incidence of carina shift. Am I right?
Yes, Karim, you are perfectly right.
Thank you, Mohammed, and you can continue with your excellent presentation.
So this is a histological image of a coronary plaque in the bifurcation lesion. As you see, This part in the middle, this piece of flesh is the carina. It's healthy. The atheroma is located here. Always remember that when you go swimming in a river, you go through the river bank. Why do you go through the river bank? Because the water is flowing slowly. The slowly flowing water, the oscillatory shear stress here is very pro-atherogenic. The atheroma is usually here. The mud is usually located at the river banks. But in the middle, you have the fastest flow. So usually the macrophage cannot penetrate this part. They do not have enough time. The blood flushes them away into the normal circulation. If you put a stent from here and you move it directly to here, once you expand this stent, this piece of flesh, this lip will move towards C. It will move here. It causes carina shift. If you are lucky enough, it will not totally occlude the vessel. But if you are unlucky and overconfident, and this piece of flesh totally occludes the entrance to this side branch, you cannot re-enter the side branch again. And if you try to penetrate the flesh, then you will get a dissection and you will get an intramural hematoma. So the next step is how to decide the angle, the carina, the extent of the atheroma. You need to record several views from more than one angulation to obtain a comprehensive picture of the lesion characteristics and to carry out the technical procedure appropriately. Of course, the hemodynamically significant lesion affecting the side branch is the one that will make you think 100 times about the two-stent strategy. It is the lesion that's located in the proximal segment of the vessel and supplies a significant amount of the viable myocardium. And how will you choose your strategy? Whether you will go provisional stenting, aiming at one stent technique, and if a complication happened, you will shift it to a two-stent technique. This is called provisional stenting. If the side branch has no lesion, if the side branch is small, less than 2 millimeter, if the extent of atherosclerosis of the side branch is less than 5 millimeter into the length of the vessel, if the side branch is easy to access, and if it is supplying a small volume of myocardium, in this case, I can say that the side branch does not exist, and I will be dealing with the main branch as a mother, as a daughter to the mother vessel. While if I'm going with two-stent technique, this is typical for 1-1-1 bifurcation, and the side branch diameter is more than 2 millimeter, the side branch lesion extended beyond 5 millimeter into the length of the side branch, or I predict a difficult side branch access from the start, like you said, Karim, if the angle is acute or if it is supplying a large area of myocardium. I will wait here for a minute for Karim to enter with his comments.
So, Muhammad, thank you for the last slides. Let me ask you some questions regarding the angiographic views for illustration of the bifurcation lesion. Let's talk about every important bifurcation lesion. For example, if we have the left main with LAD and circumflex, which view would you choose?
You need to have a caudal view to show the distal left main bifurcation. You need to have a cranial view for the ostium of the left main. So I would go with the LAO caudal, or also known as spider view, for the bifurcation between the left main, LED, and LCX. And to visualize it from another view, I will take the PA caudal or the right caudal.
What about the LED diagonal?
The LED diagonal, usually you search in the, if it is the first diagonal, so it's arising from the proximal LED, you can see it very well in the spider view also. But if you need to see the second or third diagonals, it's better to take a cranial view, like a PA cranial or a right cranial view.
And LCX, obtuse marginal?
LCXOM for the first one, if it is a highly bifurcation, the right caudal view will do very well for the LCXOM, and the PA caudal will also do well. If you want to see a distal bifurcation, a dominant circumflex giving a PDA distally or something, then you need to move to a right cranial view.
And lastly, the distal RCA bifurcation.
The distal RCA bifurcation, you need to have, you take first the LAO view, the regular LAO, to visualize the proximal and mid segment of the RCA. Then you will move more caudally to see the distal, and you will move more cranially to see the proximal bifurcations.
Thank you so much, Muhammad. And regarding choosing the strategy, if you how you mentioned the criteria for choosing the provisional strategy and two-stent strategy. However, in the most of cases, which strategy would you prefer?
Okay, let me say that provisional stenting is usually much better on the long term. Although you may get out of the cath lab acutely unsatisfied or not 100% satisfied, because what you see in the cath lab is usually not what you see after 1 year. So, as we said, provisional stenting wins whatsoever because it uses one stent, so long as you have a TIMI-3 flow in the side branch. But if from the beginning of the start you have a very big diagonal artery or a very big OM artery, I'm not speaking about a left main because this is a specific type of bifurcation. I'm speaking about LED diagonal, I'm speaking about circ OMs. If you have a very big OM from the start that is the same size as the circumflex, then consider using a two-stent strategy, especially if the ostium of this side branch is affected. And you already from the start predict that it will be difficult to access. If you did a left circumflex direct provisional stenting, you may lose the OM totally, not only by carina shift, because carina shift, we speak about carina shift in a healthy ostium. But if you have a diseased ostium, it is definitely a plaque shift. And this is much more difficult to access than carina shift.
Thank you, Muhammad, for the great illustration. So please continue with your presentation.
Yes. So what is the tools that you use during the PCI? Of course, you guiding catheter. You choose the guiding catheter with a very good support, and you choose the size of the guiding catheter. Most of the 6 French guiding catheters, you can go with two-stent technique, so long as you're going to end by final kissing balloons. You don't need to pass 2 stents together at the same time during the catheter unless you're going to do a double barrel PCI, which is usually not recommended. Of course, you choose the wires. Usually you start with the workhorse wires and avoid using extra hydrophilic wires or wires with super penetrative power, because you will end up with complications. Of course, the balloons, the FDA balloons, are actually more better regarding their profile, and you can easily pass 2 FDA balloons, or you can even pass 1 FDA balloon and 1 FDA stent in the regular 6 French guiding catheter. And of course, when you take the stents, usually now in 2020, all the stents available in the market are open cells. Previously, we had some closed cell stent which had a difficult access to the side branch. But now, most of the stents, actually nearly all the stents, are available in the form of open cell stent. Now we move to the essential steps in any bifurcation intervention. And number 1, I would say wiring of the both vessels, and this is totally debatable between PCI operators. So one PCI operator may say, no, I only wire the LED, I go from left main LED. This circumflex is a very big vessel. Yes, the circumflex is a very big vessel, and yes, the more big is the vessel, I mean the ostium of the vessel, even if carina shift occurs, usually it's very difficult for this very small piece of flesh to occlude the very big ostium. So mostly you would be able to rewire, but take care in the LED diagonal, in the circ OM, that if occlusion occurs due to carina shift, it will be more difficult for you to wire, especially if the angle is acute and the carina shift can totally occlude the ostium. Number 2, you need to assess the diameter of your landing zone by the stent, because you choose the stent according to the distal landing zone diameter, and then you expand the stent proximally by your non-compliant balloon. Of course, you need to assess the angle of the bifurcation because this will affect your technique to be used, especially if you're gonna decide to use a two-stent strategy. And here we say that if the angle is less than 70 degrees, you will move towards the stenting by two-stent technique, crush technique. But if the angle is more or less towards a 90 degrees, then you can use one of the T stenting techniques. I would wait here for Karim for a minute if he needs to ask any questions.
I'd like to make a vote on the YouTube and Zoom regarding the routine wiring of both vessels, both the main branch and side branch. And let's Haitham and let's see the result of the vote on the YouTube to get our attendee involved in this nice presentation. So
This is
Haitham,
actually a tough question, and I would like to hear from the viewers after all what we explained and what we said. I would like to hear their inputs about the real life practice. Would you wire both vessels routinely, the main vessel and the side branch, or would you have more confidence towards provisional stenting without wiring of the side branch, because you are a very experienced operator and you can pass your wire through whatever carina shift happens?
and you should also, Zahran, mention some advices for the early career fellows dealing with a bifurcation lesion. I think there is advice for the fellows and advice for the expert regarding the routine wiring of the both vessels. Am I right?
Yes. Usually, the early ones will do rewiring for both, and the very old ones will do wiring for both because they learned a lot in the middle. But usually, the middle careers like me and yourself sometimes do not wire. So usually, the very experienced operator will go towards safety and he will wire. Usually, the very junior operator will go towards safety and he will wire also. But usually, the intermediate operator will say, okay, let's play some brave games. And then after several years, he will say, my heart cannot tolerate those brave games, so let's go safe again.
Okay,
Do we
at
have some
YouTube,
votes, Haitham?
Right.
yeah, you can hear me.
Yes, I can
Yes.
hear
At
you very
YouTube,
nice.
we have both categories. Some are preferring to wiring both branches as a routine, and some other votes are with wiring only the acute angle vessels, and if the angle is not acute or difficult, we will just wire the main branch.
Okay.
So these are the answers from the YouTube.
Thank you, Haitham. And here on the
This is very real life answers. What do you have from a Zoom experts?
here on the Zoom expert, also we have mostly yes. Dr. Hatem Sukari, Dr. Ahmed Abdulaziz, Dr. Ahmed Muhannad, they agree to do a wiring, but not in every single case. And especially if we have a small side branch, they might omit wiring this is small side branch.
This is right. This is also real life practice. Let me tell you that once I was hearing a lecture, I think Karim was attending this lecture with me for famous Professor Colombo, and he said like, okay, even if I have a septal, I will wire the septal. So keep this always in your mind that one of the most expert, if not the most all across the world, can wire the septals arising from the LEDs because he wouldn't like to lose a healthy vessel. So what's pro or what's with wiring of both vessels? It helps you always to maintain the access to the side branch. And usually we hear some silly comments about what is the value of leaving a wire in the side branch? Oh my dear, the leaving the wire in the side branch is like putting a very small rock a very small rock at the entrance to the door before you close the door. This very small rock will keep the door open. And behind this rock, you can slip your finger and you can open the door. But if this rock is not there, the door is totally closed. And to penetrate, open the door, you need to break the door, you need to dissect through the carina, and you need to penetrate the flesh. Number two, this will allow the modification of the carina shift, because sometimes, although it is just carina shift, but it can cause less than TIMI 3 flow. And if you get less than TIMI 3 flow, even if the vessel is osteally healthy, you need to recross again, and you need to give a simple balloon dilatation to see what is the result of what you did. Finally, it marks the side branch for a salvage procedure. This salvage procedure, we will explain it later. The fourth, it can help you to anchor your guiding catheter, because as you know, once you have two wires in two different directions arising from the guiding catheter becomes more stable. It's like you have a table that is moving to both sides. If you fix it from one side only, it can move to the other side. But if you fix it from both sides, it's steady in place. And it helps you in the bailout situation. Let's say that a perforation or something happened and you need to emergently pass a graft stent. You have a second wire already in your diagonal branch. You can take it out of the diagonal and you can pass your graft stent across this wire to the LED while you have your balloon inflated in the LED, because if you deflate the balloon, the patient will tamponade. So usually having two wires is better than having one wire. And this is the side branch salvage procedure that you can do across the jailed side branch. Let's say that you have this wire here passing behind the stent struts, and after you put this stent into the main vessel passing to the side branch, this little piece of flesh called carina occluded the ostium of the side branch. And you cannot recross by a third wire from here directly to the side branch. So you can pass by a very small balloon here. You can open a very small area here for this side branch where you can recross by your third wire again after you inject the dye and you see the proper anatomy, and then you take off this jailed wire outside the vessel totally, and then you do an appropriate pot here so you prove that this stent is very properly opposed against the vessel wall. This is called side branch salvage procedure. Usually you do this if this side branch is extremely valuable and losing it will cost so much, also in cases of you lose the circumflex. So the other opinion will jump, the other extreme opinion. So we have one extreme opinion, do not use two wires. Okay, so we are defending the side branch now. So the other extreme opinion will say, okay, so not to lose the side branch, I will make a routine side branch pre-dilatation. What do you think, Kareem, about routine side branch pre-dilatation?
As you will mention, Muhammad, the routine side branch pre-dilatation is discouraged in the different bifurcation guideline. And this is due to the risk of inadvertent dissection during the pre-dilatation of side branch, making the access to side branch is very, or rewiring this side branch is very difficult if you need it later in the bifurcation PCR.
Yes. If you routinely do a pre-dilatation to your side branch, then you are routinely transforming yourself to a two-stent doctor. Because if you routinely do a pre-dilatation in a very, very good amount and very good proportion of your patients, you will get a dissection. And this dissection will mandate you to make a two-stent strategy. Pre-dilatation of the side branch is necessary if you already decide that you will make a two-stent strategy from the start, and this side branch will not be able to appropriately deliver your stent. So if this side branch has a subtotal occlusion or a long atherosclerotic lesion, or the lesion or is calcified and it is difficult to access, in this case, you decided from the start that you will use a two-stent strategy. And if you decided from the start that you will use a two-stent strategy, then it is better to do a pre-dilatation of the side branch, because this will help you later on with delivering your devices and equipment to the side branch. Choosing your stent diameter, as I said previously and as we explained, you choose the stent diameter according to your distal landing zone. Distal landing zone. And then you expand your stent proximally by the non-compliant balloon. Karim, do you have a comment about what we said previously? Karim?
So I have a comment regarding the choosing stent diameter. Here, the rule of to have a dimension or to measure the dimension of the three segments, the main proximal branch, the main distal segment, and the side branch, it's very important. And you need to know exactly the size of the distal main branch segment to choose your stent diameter. If you choose a larger stent diameter, you might risk losing your side branch. You might risk causing a dissection in the main vessel, in the distal segment of the main vessel. You might risk that causing carina shift. All of these consequences you will have if you have a large stent diameter. So,
Yes.
Muhammad, let me ask you a question from the YouTube about the jailed wire. This is a question from Dr. Hagar Mustafa. Could the jailed wire be entrapped and you, in some situation, you couldn't remove it?
Yes. Yes. Okay. So let me explain what Karim said previously. Here we have a bifurcation lesion, and in option number A, we have two options. Let's choose the stent according to the distal size, and then choose the stent according to the proximal size. In option A, we chose the stent according to the distal size. What we got is the carina is in place, there is no carina shift, but the stent here is not well opposed against the main vessel. Option number B, we chose the size according to the mother vessel. So here the stent is very well opposed to the mother vessel, but it's oversized here, and this oversized causes the carina to shift towards the side branch. So how do you overcome this? You overcome this by doing the pot technique. You choose your vessel, you choose your stent according to the distal landing zone size, and then the part which is proximal to the carina, this part only you inflate it by a non-compliant balloon, which is called pot technique, proximal optimization, and then you will end up that this part of the stent takes the shape of the main vessel without involving the carina. Of course, if you do this technique with your wire jailed here in this side branch, as Hagar asked her question, you may get a jailed wire. And then you try to pull out this jailed wire. 99% of the cases, if this side branch is healthy, usually the wire comes out very smoothly. Why? Because this is a metal here from one side, but from the other side you have healthy vessel elastic wall, so you can pull your wire very easily. But if This wire is jailed between metal and calcium, or metal and metal. Previous stent or two stent strategy, you're doing a decay crush or a mini crush, and you did not take off the wire from the side branch. You get a jailed wire. And let me say, if you are doing a mini crush and you forgot to take out the balloon, you will get a jailed balloon. So what should you do? In this case, you will start to retract your wire gently until it stops. If it stops, you can pass a small balloon over the wire to make a very small dilatation, and then you can take out the wire from the side branch and do a pot at the mother vessel. Of course, if you did it with a decay crush or a mini crush, you have to inflate the balloon that is already jailed a little bit so you can take it out, and then you can finish your steps consequently. What if I'm taking out the wire, I manipulated with extra force, and the wire got cut? Usually, the wire is not cut. Hydrophilic coating of the hydrophilic wire that gets stripped off the wire like you peel a potato. It's the peeling of the potato. But because it's radio opaque, you can see it. Even if a part of the wire is cut, no problem. This wire is a piece of metal, and the stent that you put is a piece of metal also. So long as this wire is under the metal or covered by a metal, no problem. So someone will ask, what if this wire is not covered by a metal? If this wire is not covered by a metal and not floating within the lumen, it's attached to the wall, no problem. If it is floating to a lumen, then in this case, you need to make it opposed to one of the walls by performing stenting. So you will put a stent to cover this wire and put it properly adjacent to the wall. So I cannot pass a snare from the left main stent to the circumflex to take out the wire. Of course, you cannot pass a snare through the left main stent to the circumflex to take out the wire. And do not ever pass a snare into a coronary branch. Usually the snare maximally is in the very proximal part of the coronary. Otherwise, the snare will cause severe injury to the side branch. There are several techniques to take out the devices, the microcatheter that's broken, the balloon, and we have a full session for complications. That's the final session, and I promise you we will discuss all the available techniques, tools, and devices to take out broken devices inside the coronaries. You have any more questions, Karim?
So does it differ to use hydrophilic or hydrophobic wire, Zahran, with as a jailed wire as a final comment?
I have two answers. I have answer from the experts. Personally, I asked Professor Jean Fajadeh 7 years ago in 2013. Professor Fajadeh, what about jailing a hydrophilic wire? And Professor Fajadeh said, no problem at all. Hydrophilic wires at that time, 2013, are of very good technology, and usually they are not broken. The other answer is my own experience, which does not matter at all, and we do not build science upon personal experience, but this is my own experience. I have more than 10 broken wires, and all of them are hydrophilic wires. So usually for me, I do not trap hydrophilic wires. Maybe because most of the cases were calcified, re-intervention, metal against metal, and so on. Maybe because I'm not a very good operator, also maybe. But however, for me as a beginner, let's say that I'm learning, as a beginner, I will not jail a hydrophilic wire. I usually jail a floppy wire.
So the personal experience is respected. Mohammed?
Yes.
So your personal experience is respected. However, I don't think there is a problem of jailing the hydrophilic wire as Bajadi. I think most of us has a good experience with using the hydrophilic wire as a jailed wire, and this is left for the operator experience, and your experience is
Yes.
restricted. And if I have the same situation of the same nightmare as you, I won't do that, but. I don't think that most of us had a problem with using the hydrophilic wire as a jailed wire.
Yes, unless it is jailed between metal and calcium
Yes,
or jailed between metal and metal, usually 90% of the cases go smoothly. So what is the value of the pot technique? It allows you to make a full expansion of your stent at the main vessel, as we said previously. And this is very important because you size according to the distal landing zone, so you need a full expansion proximally. Number two, it allows you to make a proper rewiring jacket, rewiring under from the stent lumen rather than passing under the stent struts, and it facilitates the wiring of the side branch because it widens the main branch stent struts opposing those side branch. As we said here you have wider area, and this wider area will help you to make your recrossing. And then we move here to show you angiographically. This was the baseline from the LED to the LED, and the diagonal looked very healthy. And then I put a stent from here extending to there. This is the end of the stent. And this piece of flesh called carina moved to occlude the side branch of the diagonal branch. This is called carina shift. What did I do? I just simply made a rewiring and I made a balloon dilatation to the side branch. Okay, so this simply is very easy to do. So what is rewiring? How to do rewiring? Usually you do pot first, and this pot first allows you to expand your stent opposite to the ostium of the side branch, and you make the rewiring across the distal cell, not the proximal cell. And then you do the final kissing inflation using short non-compliant balloons. And remember that final kissing inflation is mandatory if you're performing a two-stent technique. And simply looking at this 3D OCT reconstruction, if you rewire the side branch from the proximal cell versus rewiring from the distal cell. Here, you wire from the proximal cell, you pass the balloon, you make a dilatation, and this is what you get. But if you wire from the distal cell and you pass your balloon and you make a post dilatation, this is what you get. What you get here is scaffolding, as we say, that this scaffolding of the lip, which protrudes more from the side branch in the acute angle, offers you here a double benefit. The first one is the proper geometrical ostium. Compare this one to this one, the proper geometrical ostium of the side branch. And number two is scaffolding of the lip that protrudes more towards the main vessel, which is the problem with the angle of 70 degrees or less. Final kissing inflation, and this is the final slide. Final kissing inflation corrects the side branch compromise. It corrects the deformity of the main branch stent. It allows scaffolding of the side branch stent properly, and it causes the carina to be reconstructed. You move the door between the two rooms to the middle area, so both rooms ostia are open together at the same time. And thank you very much, Kareem, Abdurrahman, and all the audience. If you have any questions.
Thank you, Muhammad. Very, very nice illustration of the bifurcation essential. We have here a question from Dr. Haytham Suleiman about the tips regarding wiring from the distal cell during the bifurcation PCI.
Yes. We can wire the distal cell and we can use some special techniques to help us. Number one, you can wire the distal cell with the reverse fishing rewiring technique. You pass the wire through the main vessel stent, and you extend your wire to the main branch, and then you start taking your wire proximally. And the more proximally you take the wire tip will jump through the distal strut first before reaching the proximal strut. This is one technique. The second technique, you can use the magnification, and you can use the higher dose of radiation for a few seconds. It will give you very good visualization of the stent, and it will give you a very good visualization of the side branch ostium. After you rewire, you can pass a very small balloon across the main vessel, and you can ask the technician to give you a stent boost. When he gives you the stent boost, you can see the struts very well, and you can see your wire passing through the distal strut or through the proximal strut.
Excellent, Zaran. And Mohannad, Dr. Ahmed Mohannad asking about the type of the stent used in the bifurcation BCI. I think you mentioned that you are using almost always drug-eluting stent. Am I right?
Yes, of course, drug-eluting stents is mandatory. You have some dedicated bifurcation stent, but usually we do bifurcation by the regular drug-eluting stents. All of the available drug-eluting stents in the market now are open cell, so any one of them can be used very easily for bifurcations.
Okay, I have just a small last tip to be added regarding the removing of the gelled wire. While removing the gelled wire, we should be cautious about the motion of the guiding caster. You might find your guiding caster jump into the proximal segment of the vessel, either the mainly the left main or the proximal RCA, and causing a dissection in this vessel. So we should be cautious while removing, and we should look for our guiding caster while removing the gelled wire. Do you agree, Muhammad?
Yes, of course, of course, of course. This is very important, and this is a very good tip to deal with this situation.
So, do you have any comments before wrapping up this very, very beautiful presentation?
Thank you, Kareem. I would just take 2 points to focus. First point is whatever you do, whatever is the best technique you do, just remember that you have a 36% restenosis with the two-stent technique, so take care. So it's always better to perform provisional stenting by one stent technique, even if you come out of the cath lab a little bit less happy with a little bit less money. Number two, wire the side branch if you feel that the side branch is valuable and you don't want to lose it, because as we explained, the carina shift, it's a piece of flesh occluding the side branch. If it totally occluded the side branch, you need to penetrate it. And if you penetrate it, you are making a dissection and an intramural hematoma. I have never seen someone with 100% carina shift and succeeded to open the side branch. Especially that you are not only facing the side branch, you are the carina, you are facing a piece of metal overlying this carina. And you do not know if this piece of metal is simply one strut that is thin strut, or maybe a welding between the two struts, which is a little bit thicker. And in this case, you can never penetrate.
So thank you, Muhammad, again. And to conclude, keep it simple. Bifurcation stenting is the solution in most of bifurcation BCI. Try to understand your bifurcation characteristic as shown elegantly by Muhammad, regarding the size, regarding the side branch, regarding the angle, carina, and try at the end to optimize your result. The bot is necessary in every bifurcation BCI, and you might take several views to better understand your bifurcation, and you should select a working view for doing your bifurcation BCI. So I think we should move now to Dr. Ahmed Kamel and Dr. Abdurrahman Gamal for illustration of a very elegant bifurcation BCI. So the mic is with you, Dr. Abdurrahman.
Thank you, my dear friend Karim Mahmoud. Actually, I want to thank my dear friend Muhammad Zahran for this marvelous presentation, which I believe will be the benchmark or the cornerstone which will introduce all of us towards the world of bifurcation. Muhammad actually presented every detail for us to know the fundamentals for bifurcation techniques, assessment, and to go through this module or campus. And I want also to thank Karim Mahmoud for his excellent moderation of this lecture and his to the point questions and answers also from Zahran. We will wrap up at the end of this webinar. But for now, we will move to my dear friend, Dr. Ahmed Kamel. Ahmed Kamel is one of the best consultants of interventional cardiology at National Heart Institute. And for myself, I used to learn a lot from him. Today, he will present a nice case which was planned to be a provisional strategy to a bifurcation lesion through right radial approach, and he faced many surprises during this BCI. Please, Ahmed Kamel, the mic is with you.
Thank you, my dear friend Abdurrahman, for the nice introduction. I think I have shared my screen. Can you see my slides?
Yes, we can, Ahmed.
Okay. Thank you again, Abdurrahman. I will go on with my presentation. The clinical background of this patient: he is a 45-year-old man, hypertensive, dyslipidemic, and ex-smoker. And he had an acute attack of chest pain in June 2016. This case was done 4 years ago. Actually, there are some PCI steps that were not mandatory at that time. 4 years ago, we didn't have, for example, the final pot. It was not mandatory. It was not a mandatory step after doing the final kissing. It was not mandatory to do final pot. At that time, this patient went to the ER where he had an ECG and an echo. Troponin, one set, it was negative, but the ECG showed deep symmetrical T-wave inversion in the anterior leads. This patient was asked to be admitted to the CCU, but he refused and preferred to go home against medical advice. This is his ECG. As you can see, deep symmetrical T-wave inversion in all the anterior leads, and he refused to be admitted in the CCU, and he preferred to go home, and he was prescribed these medications: aspirin, bisoprolol, statins, and nitrates. But 2 months later, in August 2016, he had recurrent attacks of chest pain on regular effort, although he was compliant on his medications. So I saw him in an office visit, and I asked for a new echo and an ECG. The echo was okay. Ejection fraction was 65% with no resting segmental wall motion abnormalities, and the ECG was the same as the old one. But because he had this change in the ECG and he had chest pain, I preferred to go for an angio. Can you hear me, Abdurrahman?
Yes, I can.
Are you following? Okay. So
Yes.
This is the angio. This is right radial approach. Actually, when I go radial, I prefer to start with the right Judkins catheter first because it's more straight. So if I have any kinks in the radial arteries or the brachial, it goes easily, more easier than the left Judkins catheter. So this is the first view, the first shot of the right coronary artery of this patient. It's a very big vessel, free of diseases, free of stenosis, looks dominant. This is another projection of the same vessel. As you can appreciate, it's a big one giving a PDA with many septal branches. No stenosis are seen. And then the left system, as you can see, this is the epicaudal view. You can see the left main is okay. The CX and the big OM are okay. They look fine. But as you can appreciate here, I'll just move the cursor. There is something here in the LED. So another projection. This is the spider. Another one. This is the right cranial view. And as you can see, there is a bifurcational lesion. You can call it a 1-1-1 Medina bifurcation of the LED and the diagonal branch. Another projection. As you can appreciate here, the diagonal, it's a moderate size vessel. I can see it's a huge one, and I can see it's a small one. But its ostium is severely stenotic. It's severely affected. Actually, it's more diseased than the LED, as you can see. So I don't know our audience on Zoom and YouTube, how can you tackle this lesion? How can you treat this patient? As you can, this is another view. This is the left cranial. As you can see, the diagonal ostium is severely diseased. It's like a pinpoint.
So Ahmed, to make it easy, now we have a patient who presented with acute coronary syndrome, and the patient at that time refused to be admitted or
Sure.
to or to go directly to cath lab. I don't know what is the risk stratification, but I believe that is of no value because the patient already went back home, and he presented again with another acute coronary syndrome. Am I correct?
Actually, the second attack was with regular effort. We can just say it's an unstable angina with low workload, as you can just call it an unstable angina. But his ECG changes were actually was very scary. The deep T-wave inversion, it looks like a Wellen syndrome. So I prefer to have him to send him to the cath lab at once.
He was more or less stable.
It was an office visit. He came to me in the clinic, not in the ER as the first time. The second time was in the clinic.
Okay. Okay. So we can ask our dear friends on Zoom and on YouTube regarding this situation, regarding the anatomy of the LED diagonal bifurcation.
So I have a question here.
Okay, please.
For all audience, for all our audience, the experts in Zoom and other followers or viewers in the YouTube, will you go provisional or will you prefer an upfront two-stent technique from the beginning? Can you hear me?
Yes.
So is it an upfront two-stent technique or just provisional strategy? What will you choose? What's your preference?
Okay, we have here Dr. Haitham Sulaiman from YouTube. Most of YouTube voted for two-stent strategy from the beginning. Ahmed Mohannad, wiring both vessels, stent LED, bot, rewire, two kissing, and try to go out without stenting diag. Ahmed Abdelaziz, I will always go provisional. and shift to two stent if obligated. Karim Mahmoud will go for two stent strategy from the beginning, big crush mostly. Ahmed Saeed will also prefer two stent strategy. Please, Ahmed, tell us what did you do?
Okay, so because of the severe chest pain, recurrent attacks, and the significant ECG changes for this gentleman, I prefer to go for a provisional technique from the start. But actually, because the diagonal ostium was severely diseased and severely stenotic, as I said before, it was like a pinhole ostium. I prefer to predilate the diagonal ostium first before I stent the LED. Actually, you can tell which vessel is the culprit. In this case, if you can call it a culprit, if you can call it an ACS, which vessel is responsible for the symptoms? Is it the LED with that it's not significant, or it's not a very tight lesion in the LED, but the diagonal is very tight. It's like a pinpoint, as I said. So you can tell which one of them is the culprit in this case. So I prefer to predilate the diagonal ostium first, then to stent the LED across the diagonal. Actually, this is one of the most famous papers or researches that addressed the difference or the comparison between one stent technique and two stent technique. This is the Nordic 1 bifurcation trial. It's a very old one, a very old trial, nearly 14 years ago, and they compared two sets of patients, one set with provisional and the other set with an upfront two stent technique, regardless of the technique, or whether it's TAP or Keylot or crush. But they had two groups of patients, one group treated with upfront two stent technique regardless of the strategy, and the other group was treated with provisional stenting. And they found that there was no difference in side branch patency, but the two stent technique group had more fluoro time, more contrast, and there was no clinical benefit after all of this. Then they had another follow-up for this trial, 5 years follow-up of Nordic bifurcation 1 study, and they had the same conclusion that there was no difference between provisional and two stent technique from the start, but two stent technique is more time consuming, more contrast consuming, and more radiation consuming. And they concluded that it's no difference. They can, that the provisional stenting strategy is better than the two stent technique from the start. So let's go to our case.
Ahmed, before you go to the case, we have some good questions here. The first one is a very good question from Karim Mahmoud. Which vessel would you wire first?
Actually, you can just, actually, it's a trick question, but for me, I will just push the wire wherever it goes. I am planning to wire both. So I will just, my first wire, I will let it go wherever it goes. I need two wires. I will just wire both of them. So my first wire, it doesn't matter. But in the second wire, I will just try to target the non-wired vessel. I don't think it differs. I don't know what's your opinion. I have a question here for the audience, for the YouTube audience and for the Zoom audience. This is my question. Would you go for a 7 French sheath femoral, or would you continue through the 6 French radial axis, or would you go sheathless 7 French?
The question, please, Ahmed.
Would you go 7 French? Would you transfer to femoral? Would you shift to femoral at this point? You know that you have a bifurcation PCI. You will go provisional, or you go upfront to stent, whatever. But if you are going provisional, you may need a second stent in the side branch. So will you prepare yourself with 7 French femoral? Would you shift to 7 French femoral, or just continue with the 6 French radial, or you would go for a 7 French guiding sheathless through the same radial axis? What do you think?
Okay, we will wait answers from our friends on Zoom and on YouTube. Which one you will choose? You will shift to 7 French femoral or radial 6 French as we begin this case, or 7 French radial sheathless. Okay, we're waiting for a minute. Regarding my comment, which vessel to wire first? For me, I always wire the more angulated or the more diseased or difficult vessel. Here, I will try to wire the diagonal first. And Karim comment, a nice comment, that the recommendation of the European Bifurcation Club is to wire the most critical first. Is there any answers, Dear Haitham and Ahmed Saeed from YouTube?
Yeah, YouTube is voting for continuing with a 6 French sheath. It will be no problem. As we are going to provisional or 2 stent technique, that will be no problem to continue with the 6 French sheath. And I was adding that if we are having a wide internal diameter guiding catheter, 6 French guiding catheter, this will make the job more easier with the 6 French sheath.
Okay.
That's what I did. Actually, I kept my 6 French radial sheath in place, and I took an EBU 6 French guide, EBU 3, not 3.5, and it was one with a large inner diameter, 0.071 inch. This is the launcher guiding catheter. As you all know, it was available at that time, 2016. It was available in the Egyptian market, so I took it because it would be easier to use it with the 2 wires and maybe casing the loan or something. So I took this.
So if I can interrupt you, and it is still available, I think.
Actually, after there was 2 or 3 years back, 2017 or 2018 until 2020, it was not available in the market, not in the private sector or in the governmental hospitals. It was not available at that time. We had a 2-year period. We missed this kind of catheters, but I think now it's available.
Yes, of course, it is available now.
Now it's available, yes.
Yes.
So I used this guide, 2 wires. Actually, I chose the 2 wires for a purpose. I had an Asahi soft wire and a PT2 LS guide wire. I used the PT2 LS in the to wire the LAD, and the Asahi wire to go to the diagonal. Actually, because I needed the hydrophilic PT2 wire to recross. If I needed to recross through the LED struts, I can use the hydrophilic PT2, and I avoided the PT2 in the side branch. Avoided to jail the PT2 hydrophilic wire in the side branch. It's easier to use hydrophilic wire to cross the stent. So always put the hydrophilic wire. This is one of the tips. Always put the hydrophilic wire in the main vessel. So avoid to jail it in the side branch, and then you can use the hydrophilic wire from the main vessel to cross the stent struts to go to the side branch if needed. Then I took a balloon 2.0 by 15 millimeters to predilate the ostium of the diagonal. Actually, I thought that the ostium is a pin point ostium. So I prefer to predilate it first, but actually it seemed that I was wrong. Let's go to the case. The next this is so
But
now
what do you think about this angle?
actually it's like 70 degrees angle. This is I wired the diagonal first before wiring the LED. Actually I pre-dilated the ostium of the diagonal before wiring the LED. Then I wired the LED, as you can see here. As you can appreciate, the diagonal ostium still, it's not that opened. Still, it shows a tight stenosis. Then you can appreciate there is a very small non-flow limiting dissection at the proximal part of this diagonal caused by the first step, the predilatation. As you can see, I just put the cursor, try to show you. I don't know if you can see it or not. Look at the diagonal at that point.
Yes, Ahmed, we can. Yes.
There is some haziness, very small haziness at the
Oh,
ostium. Excuse me?
Yes, we can see it.
Okay, so now I open the diagonal with a balloon, pre-dilate the diagonal with a balloon. Then I put my stent across it, in the LED across the diagonal, and I am now deploying the stent. As you can see here.
We have a comment from Ahmed Muhannad.
Okay, sure.
Once you pre-dilate the side branch, so you decided to go for two stent strategy. Is that okay?
Actually, my hopes were not like this. I aimed to just to open the ostium with a balloon and stent the LED and go away. My plan from the start was provisional, but I didn't want to leave this diagonal as it was, the pinpoint ostium. I wanted just to open it just a little bit with a balloon, a very small balloon, 2 millimeters, just to open the ostium before I stent across it to avoid loss of this diagonal. But actually, my balloon dilatation was not a good step. I can say it was not a good step. Actually, I had this very small dissection in the diagonal ostium, and I couldn't predilate the diagonal the way I want. So this is the stent in the LED. As you can see, this is after stenting the LED. So which one of you will leave the patient like this, and which one will try to do something else?
Okay, let us take vote, continue or stop. Please, from our friends on Zoom and on YouTube. We have 1 minute. There is also, dear Ahmed, another nice tip that we, for our more junior colleagues and fellows, we should never pre-dilate a side branch without a wire in the LED. What do you think?
Actually, the LED was not tightly stenosed. I thought it would not affect the LED when I pre-dilate the diagonal first without wiring the LED. As you can see, I did this, and there was no affection in the LED. Actually, this is
that is because you are Ahmed Kamel.
No, يا باشا.
Not for everyone.
لا يا باشا. Actually, I don't think it's this step was dangerous or risky. The LED was not that tightly stenosed, so I didn't feel afraid to pre-dilate the diagonal without a wire in the LED. Okay. And the wire in the LED passed easily. It was not occluded, alhamdulillah. But okay. My assistant told me you can't leave diagonal like this. This was my question to you all, the audience and the moderators. My assistant told me it's not right to leave the diagonal like this. You should
We have
rewire.
Professor Sukari and Ahmed Mohanad for continuation. Also Karim Mahmoud, the same vote. Ahmed Abdelaziz also stent. Karim asked for another view.
Okay.
Do we have another view to?
I don't think so. No. But I can guarantee that the diagonal was not that opened. But the patient was very stable at that point. The patient was not very stable, and my assistant told me, you haven't pre-dilated the diagonal the way you want, and you should never leave the patient go like this, and you should do either a kissing balloon, a final kissing balloon dilatation, or a second stent. So this was what I did.
Sorry, Ahmed, we have a surprising vote from the YouTube. Most of YouTube voted to stop.
Actually, now after 4 years, after doing this case, I will stop, because you, as they always say, as they always taught me, better is the enemy of good. Now we are good. I'm not so bad. The diagonal ostium is, I know it's diseased. The LED was treated. The patient is stable. Everything is okay now. But always remember that better is the enemy of good. But my assistant told me you should go for the better. Actually,
but Ahmed, now we don't only have a diseased ostium, but only a dissection.
Yes, it's a very small dissection, not non-flow limiting, and you can just see it's TIMI3 flow in this diagonal. Nothing to worry about. If I go back 4 years in time, I would stop at that time. Actually, I will hear what the YouTube audience told. I'll just stop at that point. I'll just get the image again. This is the image, TIMI3 flow, very small dissection, non-flow limiting. LED looks fine, TIMI3 flow in the LED. The bigger branch was, or the bigger vessel was treated. The smaller one is as it is. You can say that it's kept like it was before. Just very small dissection, non-flow limiting, TIMI3 flow, and everything's okay. The patient is okay, stable, no chest pain, nothing. If I go back in time, I will just stop at that point. But I did a mistake that I did what my assistant told me and tried to rewire again the diagonal and go for a kissing balloon dilatation. That was what I thought. It will be just a kissing balloon, and I will just leave it like this after kissing and go home. So I rewired, exchanged the wires.
So at that time, recommend. Oh, what this?
Actually, I left the wire in the diagonal was the Asai soft wire, non-hydrophilic wire. I took the PT2 wire from the LED, not out, just through the stent struts, and went with the hydrophilic wire through the dissection flap, and I went in the false lumen in the diagonal, and I pulled the soft wire in the true lumen of the diagonal, and I put it back in the LED without taking any cine pictures. So after I exchanged the wires, I took this picture, this cine view, and I found that I lost my diagonal. As you can see, the wire, the PT2, which is hydrophilic wire, it crossed easily through the stent struts, and it crossed more easy in the dissection flap, and it closed the diagonal. This is abrupt vessel closure due to dissection caused by the balloon, and it was increased by wiring through the stent and through the dissection flap with this hydrophilic wire that goes with the bloodstream to the dissection flap, and it closed the diagonal branch. At this point, the patient had severe chest pain. It was very severe chest pain, anxious, radial spasm, everything went wrong. Actually, pain, tachycardia, anxiety, adrenaline, radial spasm, giving morphia, giving tridil, giving everything just to control the symptoms and try to wire this diagonal in the true lumen, avoiding this flap. So actually, I used the same wire. That was another wrong decision. Actually, it was better to use a third wire, leaving the wire in the flap as it is, and using and taking another third wire, non-hydrophilic, trying to wire the diagonal in the true lumen. But it took me 45 minutes. The patient was in agony, chest pain and anxiety. 45 minutes trying to pass this wire in the true lumen. Many trials after this, as you can see now, the diagonal was lost completely, no diagonal. As you
Yes,
can see,
now we
this
have almost a spiral dissection from the ostium
yes, sure,
to the very distal.
sure. As you can see. But at that time, as you can see here, this view, the spiral dissection is can be detected. You can see that you have two plans of dissections, two flaps. One in the proximal part that was done by the balloon and increased or dilated with the wire, and you can just appreciate another dissection at that here, as you can see, right? Two flaps.
Yes.
But I have TIMI3 flow in the diagonal. That denotes that the wire is in the true lumen. You have a flap, two flaps, a spiral dissection, but you have TIMI3 flow. You can just see this previous picture with TIMI0 flow of the same vessel. As you can see, TIMI1. This is TIMI2. Maybe it's not TIMI3. It may we can say that it's TIMI2. The vessel is filling till its end. You can see.
Yes, I agree. It is TIMI2.
Yes, very slow flow, but it fills the whole vessel, not like the previous picture. I just get it back. See this one? See this one? This is no flow. This is TIMI1. Or maybe it's TIMI0. This is TIMI0 to 1, actually. But the next picture, after many trials, I had this filling. And this is, actually, this looks much better than the first picture. So I thought that my wire entered the true lumen. Actually, I was just pulling it back, trying to go in again in the true lumen. After this view, I thought that I am safe, maybe better than the previous pictures. So I used a very small balloon, 2 millimeter, a very short one, 15 or something, meter or something.
Dear Ahmed, can I stop you here, please?
Sure.
I want to ask our friends if you have the luxury to choose another wire rather than these two wires from your shelf. Which wire would you choose? Now, you lost your side branch, the diagonal, with a spiral dissection, and you have to remove that wire, the BT2 wire, and choose a third wire, a luxury which I believe in some hospitals we don't have this luxury to have a third wire. I want to vote from our friends on Zoom and YouTube. Which wire would you choose if you would choose a third wire? We have 1 minute to collect votes, and I want to ask you, Ahmed, what do you think about the BT2 wire in recrossing with a flap in the side branch?
Yes, actually, the PT2 wire is excellent wire, is an excellent wire to cross the stent struts. But because we have a flap, it was not the right choice. But in this case was a private or insured patient with the radial access, 2 stents. Now we have 2 wires, balloon. So our equipments are limited. We were short of wires, or we didn't have the budget to open a 3rd wire. So I tried to correct the mistakes using the same wire. Actually, it was not the ideal choice to have a PT2 crossing in a dissected vessel, but that's what happened. That's what happened. I used the PT2 many tries. Actually, it took me 45 minutes trying to pass this PT2 wire in the true lumen and have and achieve this TME2 flow. 45 minutes with the patient in agony, chest pain, tachycardia, radial spasm. That was actually, it was an awful experience. But alhamdulillah, after 45 minutes, we could pass the wire and achieve the TME 2 to 3 flow. Although we had a spiral dissection, but I thought that sealing the ostium would treat the dissection downstream. Actually, if I could choose another or a 3rd wire, I would have took a non-hydrophilic wire to avoid going to the flap again. The hydrophilic wires are not the ideal in dissections, but that wire was in my hand, and I had a limited budget. A 3rd wire would have been very expensive. Actually, it was not a private patient; it was insured. But the insurance companies, they sometimes they do not agree on having 3 wires and 2 stents and 2 balloons for kissing. This may be more expensive or costly for them. So when I had the TME 2 to 3 flow in the previous picture or the previous cine movie, I thought that I'm in the true lumen, and I used the 2 millimeter balloon to open the stent cells in front of the diagonal, like this. This is what happened. Now I opened the stent cells, the cell in front of the carina, like this. Took a picture. Actually, the diagonal ostium was not able to. Actually, it was very tough to predilate or to dilate. As you can see, after all these dilatations with balloons and the dissection and everything, rewiring everything, and the ostium is still, it's like a pinhole ostium. Very strange. So I thought that...
Ahmed, may I comment, please?
Yes, sure.
That may be a carina shift simply.
Maybe.
Yes. The answers from Zoom and YouTube, as you mentioned, if we will choose a non-hydrophilic wire with a better tactile sensations. Most votes go to run through intermediate, which I totally agree with. The tactile sensation with the PT2 wire is 0 almost, or very little. So please go on.
So actually, I passed this stent. It was 2.5. I think it was by 18 or maybe 15. I don't remember. But it's a 2.5 millimeter DS to go for tap. Actually, when you have decided a provisional technique from the start, you stent the main vessel, and you will do a bailout second stent technique. A bailout, you have one of 3 choices. T-tap, this is one choice. Culotte, this is another choice. Or the internal crush, which is not that a good strategy. And actually, I didn't do it before, and I will not do it in the future. I don't think crushing a stent in the bloodstream will be good. I think it may be very dangerous for the patient, for the main vessel and for the side branch. So
I think it is not well studied, the internal crush.
Yes. No studies. Yes. But if you can do an internal crush, you can do tap. So tap is a better solution than internal crush.
The angle pushes you to a certain corner.
Sure. Sure.
Yes.
Sure. But actually, I prefer to do tap, although the angle is not that favorable for tap. But I thought it was a better technique than the internal crush, and I couldn't do pilot because of the different sizes of the vessels. The diagonal is 2.5, there is 3.5. There is a discrepancy in size, so I thought that pilot technique was not the best technique to treat this complication. So I chose the tap technique, although the angle was not a right angle. This is the
So,
stent.
Ahmed, you choose a tap.
Yes.
May we take votes regarding these three options while you give us a very short note about these three techniques? If we do one of them here, please vote, dear friends. Tab, kilot, Isabel out. Tab, kilot, or internal crush.
So I'll just mention.
We use a 6-French guiding castle.
So now I'll mention the differences between the three strategies. First, in order to do kilot, you should have both vessels, the main vessel and the side branch, equal or nearly equal in size. They should be, the difference should be maximum half millimeter, 3 and 3.5, 2.5 and 3, not a big difference, not 1 millimeter. 1 millimeter is a very big difference for kilot. For tap, you can use tap in vessels with variable sizes, but you should have the angle, a favorable angle for tap, which is the 90 degrees or 70 degrees angle at least. So the best is 90. You can do it in 70 degrees angle. However, this case, the angle is about 50 to 60. Maybe it's somebody will tell it's maybe 45. And this is some drawback in this technique in this exact patient. But I did it because actually I couldn't do kilot. It would be a failure to do kilot. And the internal crush, actually, it's another non-studied technique, and I don't trust doing it. Actually, there was no many trials addressed the use of the internal crush. Actually, to do tap in a better way or in the appropriate way, you should park a balloon in the main vessel in front of the ostium of the side branch. You should put a balloon just to make sure that your side branch stent will not cross to close the main vessel. And that's what I tried, but I couldn't achieve. As you can see, I am just here. I am just trying to put the stent, just touching the side branch stent, just touching the main vessel with a very minimal protrusion, as you can see here. And I took too many angles just to make sure that my side branch stent will not occlude the main vessel. This is another view. As you can see, this is right cranial. The last one was left cranial. This is right cranial. As you can see, just very small protrusion, just touching the main vessel, just very small protrusion, not occluding the main vessel. And then I tried to put a balloon just parked in front of the ostium of the side branch. This is a contrast injection. You can see that the main vessel is not occluded with the side branch stent. Then I will get my balloon just to park it in the main vessel in front of the side branch ostium. As you can see, I couldn't push the balloon more distal. You can see here, there is a balloon just before the ostium of the diagonal, balloon the LED. As you can see, I couldn't push it distal, so I inflated my stent at that position without parking the balloon in the right place. I know the technique, I know the steps. I tried to do the best or the ideal technique, but I couldn't. As you can see, the balloon is just parked before, or few millimeters before the ostium of the side branch. But this is not appropriate, and this is not the classic technique. But maybe because I had a 6 French guide and I used balloon, it was not a new one. I think this was the 2 millimeter balloon I used to open the stent struts, and it was inflated before, so the profile was distorted and it couldn't be pushed more distal to be parked in front of the side branch ostium. So this is my final picture, or this is not the final, this is just after stenting the side branch, as you can see. So I have another step. Some other views, just making sure that the diagonal is good. As you can see, the dissection flap, the distal dissection flap is still there, it's still present, but the ostium is stented and scaffolded, and this was my final step, the kissing balloon dilatation. Actually, at that time, 2016, the final pot was not a mandatory step in all bifurcation techniques. The final pot is a new. It's not a new step, but it was not mandatory at that time. So my last step was the final kissing. Final kissing balloon dilatation was studied in many trials. I think Nordic 3 bifurcation trial was addressed this step, and they showed that it's mandatory to do a final kissing balloon dilatation in all 2 stent techniques. Or they were an upfront 2 stent.
Ahmed, can you hear me? Ahmed?
I think Abdurrahman, we lost Ahmed. He will be reconnecting soon.
Okay.
But maybe this is time for a nice interference, because this case is a very educative case. This is what I have been saying to the YouTubers with us. This is a very educative case because Ahmed is a very good teacher, and he is a brave presenter and operator. So I salute him for not being afraid to show the mistakes and how we should learn the proper practice, everyone. It's not about showing a case that I'm a hero and I saved the day. No, it's about teaching and learning points. So what we actually learned, or what Ahmed stressed upon, is everything that what we said in the first lecture. We decided in the first lecture that if you have a big side branch, you are going with a 2-stent strategy, and this is what Ahmed said with us. Number 2, if you do a pre-dilatation, then most probably you will end up with 2 stents, and this is how Ahmed ended up. Number 3, if the angle is less than 70 and you decided to do a pre-dilatation, then you would go with 2 stents from the start. This Ahmed showed that now he was stuck and he had to do a tap technique where the T-stenting, because the angle is narrow, 70 degrees, it had to be protruding into the main vessel, and this would take the risk of being an internal crush technique. And the inverted culotte technique would have been a little bit more difficult because the sizes of the 2 vessels and the recrossing procedure would have been a little bit more complex. And when you do a recrossing, or when you jail a wire in the side branch, it would have been much more easier to use this with a floppy wire. So actually, Ahmed elegantly showed in his case all the learning points, and he stressed upon them. Ahmed is an excellent teacher and educator, and he's very brave to show us what he did and what he learned, which matches exactly what we said in the first lecture. I think Ahmed joined us now, and I will pass the mic
Yes,
to
Ahmed joined us again. Thank you, Zahran, for this nice comment. Ahmed, you
Yes, I'm
joined us
here.
again.
Can you hear me? Zahran, can you hear? Yes, yes. This is the
Yes,
final.
we can
I was
hear you.
just
Yes,
showing the
Ahmed.
final step.
Welcome back.
I was just showing the final step, the final kissing. At that time, 4 years ago, the final pot was not mandatory step in bifurcation, two-step bifurcation techniques, but the kissing was a mandatory step. So that was my final step in this case, kissing after tap, and this is the final picture. As you can see, the diagonal is filled with contrast. Yes, I have a flap. As you can see, I just point with the cursor. This is the flap here. Yes, this just at that point. Flow diagonal all branches of all. You can say these are very small capillaries, if I can say that. The patient actually, although he was
Ahmed, I think the internet connection is more or less not well established.
Yes, so Abdurrahman, we are saying, or we are stressing upon the final points to be learned from this case that Ahmed presenting. We were first of all the guiding catheter. You can do with the 6 French. You can pass 1 stent and 1 balloon, and you can pass 2 balloons, but you cannot pass 2 stents. So this is number 1. Number 2, when you choose the wire, for the side branch, it's better to use a floppy wire. Number 3, when you do ballooning, if you decided to choose a 2-stent technique, then you should do adequate ballooning to the ostium of the side branch with a 1-to-1 size balloon, because this will facilitate all the next steps. Number 3, when you decide about the angle, if it is 70 degrees or less, then you will go through the crush techniques. If it is more than 70 towards the 90, then you will go with one of the T techniques. Number 5, when you do a recrossing, usually you do recrossing with a floppy wire. And number 6, as Ahmed is showing us now after the final kissing inflation, the result is very nice, except for mainly a little small dissection, which is non-flow limiting after the stent in the diagonal branch. I think this is the remainder of the spiral dissection that started at the ostium.
This is the remainder of the spinal dissection.
Yes. But it's not flow limiting, and it will be sealed by the regular blood flow.
Yes, sure.
Yes.
So now we have the LED treated. The diagonal was stented, bail out stenting, tap technique, and final kissing. Actually, if this case was done 2 years later, 2018, I would have done a final pot after the final kissing, as dictated by the European Bifurcation Club guidelines. The final pot for each bifurcation case, whether the bifurcation was a single stent technique or a 2-stent technique, final pot now is mandatory after all bifurcation cases, whether it's 2 stents, whatever the technique is, 2 stents, kilot, tap, crush, mini crush, DK crush, anything, you should put at the main vessel, proximal part of the main vessel. And also in the provisional cases, you should put also just to make sure that the stent struts are opened in front of the side branch. So my take-home messages, this is last picture, the left cranial view after stenting. Actually, the final step, the missing step is the pot, as I said before. So this is my take-home messages. You can do bifurcation in 6 French guiding system, as Dr. Zahran said. This guiding catheter I took, it was of a wide internal diameter. Actually, we have a very variable dimensions or diameters of the guiding catheters. We have 0.069 and 0.070 and 0.071. 0.071 is wider, and it can take 2 wires, 2 balloons as I showed, and maybe a stent and balloon. Actually, there was no advantage for a 2-stent technique over a simple provisional technique. Then side branch stenting should be done only in case of side branch loss or more than 75% stenosis or TIMI flow less than 3, as in our case here, the side branch was tightly stenosed, and actually it was lost before I stented it. Then remember the golden rules of bifurcation: keep it safe, keep it simple, and keep it swift or keep it open. And thank you very much for your attention. It was a nice meeting. I've enjoyed your company, and thank you all our viewers on Zoom and YouTube, and special thanks to our Professor Dr. Hatem Al-Sukkari. طبعا I don't know if he's still here or not. Thank you Dr. Hatem for joining us. Thank you Zahran, Karim.
Still here.
منور يا باشا.
I'm happy to be with you.
منور يا باشا. منور دكتور حاتم. Thank
Okay.
you كريم زهران عبد الرحمن وكل الجروب.
I have a question.
The final greetings. I want to thank my dear friend Dr. Ahmed Kamel. He showed us a very nice case with many tips and tricks.
أنا عايز أقول حاجة لو تسمحوا لي. يعني الواحد بيتعلم من أخطاء الآخرين وأخطاء. يعني الحالة دي كلها أخطاء وأنا مش مكسوف إن أنا أقول كده. بتعلم من أخطائي وأخطاء غيري. وطبعا اعتقد انا بالنسبه للاودينس شخص مختلف بعمل غلطات، فاعتقد ان هم بعد كده اللي شافوه انا عملته مش هيعملوه عشان يتجنبوا الاخطاء، لان الحمد لله ربنا يعني اكرمنا، عرفنا يعني ايه نوفركم الاخطاء ونصلح الموضوع. ممكن كان يحصل حاجه ثانيه ما نقدرش نصلح الخطا، فالحمد لله ان ربنا اكرمنا وصلحنا الخطا. فعشان كده بنحاول نوري الناس ان الاخطاء دي حاولوا يا جماعه تتجنبوها، وحاولنا نهايلايت الاخطاء. واحد ان كل خطوه فيها خطا قلنا ايه المفروض ما نفخش السايد برانش في الاول، ما نعملش ريكروسنج بهيدروفيليك واير، يعني كل دي اخطاء يعني اتعملت، لكن الحمد لله ربنا سترنا وطلعنا كويسين. فده بنحاول ان احنا يعني ايه قدام ده بنحاول يعني نقول لزمايلنا او اخواتنا اللي بيتفرجوا علينا الاخطاء دي يا ريت يعني ما يخشوش فيها او ما يقعوش فيها تاني ان شاء الله بعدين.
Thank you so much, dear Ahmed. That's actually what Mohammed Zahran mentioned when you are disconnected. You are, as all of us know you, a very brave person. You mentioned mistake and give us a real world application experience for Mohammed Zahran lecture. So we please guys, would you please mute yourselves? You give us many tips and tricks. In this case we learned a lot how we can do a successful bill out, what is correct and what is wrong, what we should do and what we should avoid. I have a final comment and a final question from Prof. Hatem Al-Sukkari. My comment is even now you can do it without final bot in this case, because if you do bot you have to have a minimal proximal length before the bifurcation, and you should also have a very short non-compliant balloon to do bot. Otherwise you would crush and do an unintended internal crush of the side branch bail out stent of the diagonal. So if you leave it as it, no one can blame you, but you have to do bot before the side branch stent. So you can do bot and then do final casing, but this final casing also must be with some tips and tricks. you have to do the kissing without re-interrupt the bot you have done before. Otherwise, you have to do bot, side, bot, and you make rush again the side branch stent. This is my comment. The final question from Professor Hatem Sukkari. Do you plan to follow up this patient, and how would you follow up here or him?
الحقيقه العيان ده هو متابع معايا من 4 سنين من ساعه ما جالي اول ما شفته يعني، وهو متابعني على طول وبيجي لي كتير. واخر مره لسه من سنه كان جاي يعمل عمليه نون كاردياك يعني جنرال سيرجري، وجالي ومفيش شكوى. انا طبعا بتابعه كلينيكال، هو مفيش شيست بين، مفيش اي حاجه حاليا. كان عامل اي سي جي ايكو، والدنيا اتحسنت في الاي سي جي، فرق رجع تاني ايزو الكتريك تي ويف رجعت يعني ابرايت تي ويف، مش ديبلي انفيرتد، ومفيش شيست بين مع المجهود. عملت له ايكو من سنه تقريبا قبل ما يعمل الجراحه، وكان ماشي كويس جدا. الاجكشن فاكتور بتاعه كان ستيل زي ما هو حاجه و60%، فهو كلينيكالي از اوكي، مفيش مشاكل. مش يعني انا طبعا خايف من اللوس اوف سايد برانش. الحاجه الوحيده اللي ممكن اخاف منها او ان انا عايز اعمل لها فولو اب لوس اوف سايد برانش. في الاخر هو دايجونال، مش هعمل له يعني انفيزيف تيستنج الحقيقه عشان دايجونال. هو لو اعتقد لو الدايجونال ده عمل له مشكله، ممكن ان انا اعمل له قسطره تاني، او هو حس بشيست بين تاني، ممكن يبقى عنده مشكله في ال اي لا قدر الله، او مشكله في السي اكس مثلا او في الرايت، يعني ممكن اعمل كده. لكن طالما في شيست بين والراجل متابعني ومجهوده كويس وعمل عمليه وعملت له يعني الدنيا ماشيه كويس، هو كلينيكالي از اوكي. فانا مش عنديش رش قوي ان انا اعمل قسطره تاني. ولكن هو الراجل يعني ما اشتكاش من اي حاجه، وبيعمل مجهود عادي جدا، فرق عن الاول خالص. هو مع رقمي الشخصي بيكلمني، وفي الاخر طلع جاري. يعني انا عرفت في الاخر، قابلته في الشارع صدفه طلع جاري، فيعني لو عنده مشكله هيجي لي.
Thank you, Dr. Ahmed Kamil, for this great experience. Good judgment always comes from bad experience.
طبعا.
Thank you.
والحالات الحلوه ما تعلمش، الحاله اللي بتمشي حلوه ستريت فورورد دي ما تعلمش حاجه على فكره. تبقى حلو، انت ما اعرفش ايه اللي اتعلمتش حاجه، انت عملتها جت معاك صح او جت معاك كويس توفيق ربنا، بس انت ما اتعلمتش حاجه جديده الحقيقه.
الكومبليكيشنز اللي بتتعلم. An excellent bill out. You do an excellent bill out. Thank you. For now, in 1 minute, I will wrap up this Kickstart webinar for our Bifurcation campus. We started with a marvelous presentation from our friend Prof. Muhammad Zahran. He gives us a very clear introduction to the bifurcation world. What is bifurcation? What's the different classification of bifurcation lesions? Stressed on Medina classification. What meant by the true bifurcation? What is the complex bifurcation techniques? And how to assess the mother vessel, the main vessel, and the side branch. How to assess the angle of this bifurcation, and gives us a marvelous illustration. What is the carina shift? What happened? What happened during this? And finally, the algorithm how to choose provisional or two-stent strategy. That actually followed by a nice case from our dear friend Dr. Ahmed Kamil, from which we learned a lot. I want to thank Dr. Muhammad Zahran, Dr. Karim Mahmoud for his nice moderation, and Dr. Ahmed Kamil. Next Tuesday, we'll have the second webinar on bifurcation. We'll stress on provisional stenting, crossover, and bailout techniques. We'll have our dear friend Dr. Haysam Sulaiman and our dear friend Dr. Ahmed Mohannad will show us a lot. Please wait us next Tuesday. Also, our dear friends all over the world, the next Thursday we'll continue our clinical webinars on Thursday. So we will wait all of you. Thank you so much and see you soon.